Good afternoon. I am Mauro Biffi from Bologna, Italy. I'm very pleased to introduce Professor Bernard Prendergast from St. Thomas Hospital, London, who is going to lead us through a very sensitive topic in the COVID era, that is the management of valve disease patients. Professor Prendergast, please.
So thank you very much for inviting me. These are challenging times for every specialty in cardiology, and I'm very happy to speak about the subject of valve disease in this challenging era of medical practice. We already know that valve disease is an increasingly common clinical problem, and even in the best of times, it's a condition which is underdiagnosed and undertreated, which presents a challenge even before COVID became an additional part of our daily work. These data from an American study and from our own study in Oxford demonstrate that in the elderly population, valve disease is exceedingly common, and of course may be asymptomatic for many years before presentation with typical symptoms of breathlessness. One of the key things is how we identify valve disease at the earliest stage and how we diagnose it in the absence of symptoms or with symptoms that may be difficult to judge. And we learned in the OxVALVE study that the presence of atrial fibrillation in elderly patients is a very sensitive marker for the presence of previously undiagnosed heart valve disease. So an important takeaway message to start with is a patient who is presenting with breathlessness, who is elderly and in atrial fibrillation, valve disease may well be the underlying cause, and that may be the threshold to determine clinical assessment and or an echocardiogram as deemed appropriate. We've also learnt over the recent years that our skills with the stethoscope are not perhaps as good as they used to be. And this sub-study from OxVALVE demonstrates that in the hands of general practitioners particularly, whilst a normal auscultation is a good predictor of the absence of valve disease, the presence of a murmur is actually a very poor indicator of the need for an echocardiogram. So in this current climate, particularly when a lot of GPs are doing virtual consultation with their patients, referral for echocardiography in suspected heart valve disease is going to be the #1 tool for diagnosis, because the opportunity for auscultation is going to be limited. We also need to bear in mind that once patients have a diagnosis of heart valve disease, their outlook can often be very, very poor, and that's particularly the case for aortic valve disease and aortic stenosis, as demonstrated on this classical historical slide, which demonstrates that patients may be asymptomatic for many years, but when they develop their symptoms of breathlessness, the outlook is very poor. And even with smooth running NHS pathways, very frequently patients become rapidly symptomatic and hospitalized with their valve disease before any intervention can be performed. So in the current climate where access to primary care and access to secondary care is limited, there is a very major danger that patients with heart valve disease may die without a diagnosis or without surveillance in a clinic, and that is a major concern. Here we can see that in aortic stenosis par excellence, that the worse the aortic stenosis, the worse the outlook. And in conjunction with other studies, we've also been able to demonstrate that even patients who are asymptomatic may deteriorate over a 1-year period and develop problems relating to their valve disease. So this slide summarizes the indicators of poor prognosis in symptomatic aortic stenosis, but many of the bullet points are applicable to other elements of heart valve disease, particularly mitral regurgitation. So rapidly progressing symptoms, particularly dyspnea, and in the case of aortic stenosis, syncope, the presence of congestive heart failure, the documentation of poor left ventricular function on an echo, very high gradients in the case of aortic stenosis, and for both aortic stenosis and mitral regurgitation, elevation of BNP levels is a good marker of a bad outlook. And you can see here in these waiting list data for patients awaiting aortic valve intervention, even within 1 or 6 months, these patients may do badly and can even die when they're on the waiting list for an intervention. So if we extrapolate that to a scenario in the UK right now, or in other countries in Europe where access to interventions may be limited, and where access to follow-up may be limited for many months, perhaps 6 months or longer, there is a very significant risk to patients of adverse outcomes, including mortality.
Bernard, I have one question that was most important in my country in the past 2 months, and it is exactly in line with what you are saying. That is, patients who are hit in the COVID pandemic mostly die because of cardiovascular, untreated or undiagnosed syndromes, just because there's COVID outside, so they don't seek medical attention and they don't receive proper treatment because of the confusing pattern of dyspnea, for instance, between a pulmonary involvement by COVID or by a failing heart. And that is really pitied because, as you mentioned, the time course of a moderate valvular disease may be extremely rapid to the picture of failure, and it would be undiagnosed.
No, absolutely. I share your concerns completely because while symptoms of COVID may be breathlessness, of course, the patient may be advised to stay at home and self-isolate, at the same time, statistically, it's probably more likely it's an alternative explanation, whether it's heart valve disease, whether it's heart failure, whether it's progressive coronary artery disease. These are, or the onset of a new rhythm.
Yep.
You know, the onset of atrial fibrillation, for example. And patients aren't seeking help, and they're not presenting to their GP, they're not presenting to the clinic, and they're not presenting to the A&E department, and this is a major concern. We should also add that we have seen some cases of infective endocarditis in patients with heart valve disease that have been missed because the patient is masquerading with a fever and breathlessness, and they're given the wrong diagnosis and they don't have the appropriate investigations, and they then present very late. And we know that in infective endocarditis, the outcomes are very poor associated with a late presentation. So always round, we're facing major challenges.
I dare say that once you have an established diagnosis of heart valve disease, even though it's not a severe one, that patient should be put on a surveillance program where you can detect early deterioration before you can be so confused by any new event that you can't rule out whether breathlessness is heart failure or is anything else. And that is a tremendous challenge and calls into practice also remote medicine.
No, absolutely. So we've had a long experience of a large valve clinic here at St. Thomas's, and we've adapted our structure to telephone surveillance very quickly because we have the infrastructure, the database, and the personnel. So we're able to identify the highest risk patients at baseline using some of the parameters that I've mentioned. And we particularly find in some patients that a BNP level at baseline is a very strong indicator of those who are going to do badly over longer term. So whilst echocardiography is very important for diagnosis, it's perhaps not so important for surveillance over a period of months. But an assessment of baseline prognosis and careful surveillance by means of telephone virtual consultation is a very good way of maintaining contact with these patients. It's worth pointing out, however, that many of these patients are elderly, so a FaceTime type consultation is often challenging because they're not familiar with or don't have access to face-to-face technology. But nevertheless, a phone call, either directly to the patient or to their family, is an acceptable second best in the present setting.
I do believe that if you establish a good relationship with the caregiver or a relative, having simple measurements of heart rate and blood pressure in an aortic stenosis patient can give you so much information that you can really jump forward deterioration patterns. So I think we have to use this approach more often than ever.
Absolutely. So we need to remember as well that intervention may play a role, and we can't wait forever for these patients. And these guidelines from the European Society, which have just been published, provide a very helpful overview as to which patients should have intervention at an early stage and the timelines of requirement for those procedures to be performed. It's a busy slide, and I'll just leave it for digestion by the audience. So my concluding messages, and important messages they are too, are firstly that valve disease is very common and easily overlooked in the best circumstances, but particularly in the COVID era. Diagnosis requires a low index of suspicion, and to make the diagnosis, you either need to listen to the heart or you need access to an echocardiogram. And we need to work out resources and pathways to allow that to be achieved, either in the community or with access to a valve clinic. Once the diagnosis has been made, however, the prognosis can be predicted from the baseline echocardiogram, the symptomatic status of the patient, and their levels of key biomarkers, notably BNP. Interventional options for aortic stenosis are important because these patients do badly over a 6-month interval, and selective use of balloon aortic valvuloplasty and TAVI are important, particularly if access to surgery is difficult due to concerns regarding ITU resources and the need for general anesthesia. Most other interventions, for example, MitraClip for heart failure and so forth, associated with heart failure with secondary mitral regurgitation, can probably wait for a period of months, as long as optimal medical therapy is in place and holding the patient. And finally, don't forget that infective endocarditis, the great chameleon, the clinical chameleon, can masquerade as COVID. And in a patient with known valve disease who develops COVID-like symptoms, infective endocarditis needs to be considered within the differential diagnosis. So I hope those are helpful, conclusive messages, but if there are any remaining questions and discussion points, I'm very happy to cover them.
Thank you so much, Bernard, for the excellent presentation. And you were able to summarize all these key points to follow those patients who have an already established diagnosis of heart disease, or those where we might suspect easily that there's an underlying valve disease in an elderly patient who has new symptoms onset. It's something that we could misdiagnose and miss with a sorry potential to treat one valuable patient. So either say we must keep this fully awake in our mind and try to have let's say, reference value of each parameter of a patient that we already know, and keep high the suspicion level for those patients who never have symptoms, but all of a sudden, they could have heart failure symptoms that we shall not misdiagnose as COVID. So many thanks for this excellent summary. And let's do our best to preserve our patient from cardiovascular death rather than saying that COVID is everywhere.
Absolutely. Thank you for asking me to take part.